is going to be a little bit different presentation than the others. So I'm just going to update you today on our pediatric pilonidal disease study. No disclosures. I'm going to go over a little bit the idea and the design, the educational materials that were developed, and a very brief dip into the descriptive and preliminary data since the final data is not available for the study yet. Many in the audience, probably most at this point, are familiar with the idea of the Gibbs procedure. Dr. Gibbs first published this in 2008 as a means of dealing with pilonidal disease using trephination of the sinus tracts and pits, using various instruments, but one commonly used one is just a skin punch biopsy, as seen in the illustration by Dr. Gibbs, and a photo pre and post Gibbs of one of our patients. So this idea was becoming increasingly discussed and popular in the pediatric surgical community, but its use was very varied amongst institutions and amongst surgeons at those institutions. Back in 2018, I proposed a prospective study looking at the Gibbs procedure in pediatric patients at our annual pitch meeting of the Midwest Pediatric Surgery Consortium, or the MWPSC. There was a lot of discussion about it. There was interest in the topic, but some concern that there was not enough pediatric data to make this standard of care and base a study around it. But the idea was accepted. So group discussion, small group discussion, multiple revisions, and a project was born. The general concept of the study was to collect both patient demographics and clinical data, and to survey the patients throughout the follow-up of 1 year to get their opinion about the disease treatment and its impact on their life. The study intentionally allowed surgeon choice, but also did provide surgeon education about the Gibbs procedure, since there were many institutions that weren't using it, and also as a means to try to standardize the way the Gibbs was being done amongst the participating centers. In addition, we provided patients with standardized information about what medical management of pilonidal disease was. I know this is going to be difficult to see, but in general, this is just kind of the flow diagram of our study, where patients have an initial contact with the surgeon and then begin in either the surgical or medical arms, and then flow down depending on success or lack of success of the various treatments. And we had educational materials at various time points during this study. This is what one of our patient-centered handouts looked like, and providing information to the patient and the families about baseline medical management to provide some consistent messaging amongst the many surgeons at the many centers. Similarly, we produced instructive materials for the surgeons, both to sort of guide the general treatment, but also to actually provide an example of what the Gibbs procedure looked like surgically. And we have a video, which I don't know, I'm gonna maybe play this for just a second, which just went through step by step of the procedure. It's narrated. We're intentionally muting the audio here, but went through sort of the setup of what you might need to do the Gibbs procedure. And then one of our surgeons who was most experienced in the Gibbs procedure actually performed an operation which was obviously heavily edited, but shows the steps of doing the Gibbs. There you go. You probably don't want to see any more hairy butts, but there, that's just kind of, it's in fast forward. There you go. In all, we had 10 of the 11 centers of the MWPSC participate. These were the participating centers. And data collection was centered in Cincinnati. Here's a timeline of this very drawn-out project. Initially, I proposed it in September 2018, applied for the APSA Foundation scholarship, and received the Grosfeld Award in May of 2019. IRB work, began. Everyone knows the pain of that. The first patients were actually enrolled in Cincinnati in the fall of 2019. With various centers joining after that. But just as the study was finally getting up and running, of course, COVID happened, and we had a long period of shutdown since this was obviously not clinically necessary research. So at some sites, there was as long as 18 months where no patients were enrolled. We enrolled our final patient in October of 2021, and our final one-year follow-up will be complete on all patients in October of this year. So it's done enrolling, but we're still collecting the follow-up data from patients. We, in total, enrolled 250 patients, which was our goal, across 10 centers. Mean age of the patients enrolled was 16 and a half and half, male and female, strongly predominant Caucasian, and our mean BMI was 29. In terms of the patient contact, they're contacted at 1, 6, and 12 months after enrollment to provide updated information and to get resurveyed. The APSA Foundation money is actually being used for graduated payments to the patients to encourage engagement across the course of the study. And then in addition, each center does a one-year chart review where we go back into the clinical chart to try to pick up any previously undocumented pilonidal-related visits or surgeries. 34, so it's about 1/3, 2/3, so about 1/3 of the patients were initially treated medically, 2/3 surgically. Of the 2/3 that were treated surgically, interestingly, almost 80% of them had a GIPS procedure, even though in the participating center, GIPS was being used very minimally before this study was proposed. And then in terms of what we're asking the patients, we're asking them a lot of different questions. They're being asked some questions about the clinical care and the course. We're asking them about out-of-pocket expenses for the care of pilonidal, since, as you know, a lot of this is not covered by insurance. And then importantly, we're asking them about their perception of the disease and how it impacts their life, since a lot of these are teenagers. Our contact is all initially done via email, but we had an exceptionally poor response rate. So we have a research coordinator who previously did work on the teen lab study and said, hey, I text the patients in the teen lab. So we started texting them, and our improvement rate has gone up significantly. We now only have single-digit numbers at each of the time points where we don't have follow-up, so that's been really encouraging. Plus, they're getting paid. But so we will reach one-year follow-up, as I mentioned, in this fall. We'll have a couple months of catching up on the last-minute patient surveys and cleaning up the data with planned data analysis in early 2023. So stay tuned. I hope to have a lot of information to share with you at a future meeting about this study. I'd like to acknowledge the MWPSC. Without my collaborators in the group, this would not have been possible. Dr. Alex Kassar and Amelia Collings, our two surgical residents, have been involved at this project in various time points and have helped carry it forward. Of course, thank you to the APSA Foundation and all of its donors for believing in and supporting this project, which, as you might notice from the agenda, doesn't really fit in with the rest. To my partners, Dr. Rosen and Brown, who really love pilonidal disease and have helped move this along and have helped me create the educational materials, and our rockstar clinical research coordinators. Thanks, and happy to answer any questions.
I want to reassure you that this fits very well into this program, because I think we're all struggling with this disease, and I welcome any questions from the audience.
Upperman, Vanderbilt. Quick question on your slide where you said the initial therapy was a GIPS procedure. Are you suggesting that they all presented acute and you immediately operated and done GIPS? I mean, that sounds a little atypical. It seems like they would have had some degree of antibiotic therapy and then come to the surgeon. So I was a little unclear as to that data slide. Yeah, so that's with the initial contact with the surgeon. So some of them may have been seen in the emergency room treated with antibiotics. You know, there was probably a clinic visit where the disease was temporized and they were scheduled for a GIPS, but the first planned intervention was a GIPS procedure. As you can see, like 16% had an IND first because they presented actively with an abscess that needed to be dealt with first. Quick follow-up. What was the time between the initial disease presentation and the time to initial procedure? I don't have that information right now, but we do have that in the data set.
Steve Stylianos from New York. Thanks for the shaving video. That was great.
It gets better. It gets better.
I bet. Any downsides to using peroxide?
I mean, I don't know yet, but Not that I'm aware
Any
of.
upsides to using peroxide?
I'm not a firm believer in either or, so I don't really have a lot of skin in that game. I know some people use it, some people don't. I don't think there's a lot of data. We do have that as part of our data collection, whether or not it was used, so maybe I'll be able to answer that question for you next year.
All right, I have one final question. Did you survey the providers at all? You mentioned that the providers, in the end, 78% of them use skips, but initially not so much. So how did they find the education process and taking this on?
We did not specifically survey the providers, although it is a small group within the MW PSC, so it's certainly something we can go back and do. We realized halfway through the project we didn't really set it up for like an implementation study, so it was hard to go back. But I do think that there is some learning to be seen from, like, you know, introduction of a new-ish kind of procedure. I think GIPS was a nice one to start with because it's not a technically demanding procedure. You know, once you understand the steps and have done a few, it's something that you can easily teach others to do.
All right, thank you.
Thank you very much.